Chuck.
Let folks come on in now.
Hello, folks. We are here at Netroots Nation in Philadelphia, and we are just waiting for the Medicare for All panel to begin. We've got state legislators here to talk about how we are going to get to Medicare for All through the states. And yeah, we are very excited. They're going to be beginning in just a minute. Everybody settle in, grab yourself a drink, and get comfortable and get ready to get inspired about the future of Medicare for All in this country.
Are we ready to get started? From our daily folks?
Oh, yeah.
Okay.
All right. Good morning.
Good morning.
How are we all doing today?
Good morning.
Good morning.
Good. My name is Reverend Dr. Rodney Sadler. I am a resident of Charlotte, North Carolina. For a long time, I have been working on this notion of Medicare for all. The idea that we need a single-payer system in the United States of America to make sure that we understand healthcare as a human right. It should be something that should be unencumbered by things like profit and profit motives. It should be something that we have as the nation the ability to make sure that everyone is covered. Everyone's needs are always met. And I've been working on this for some time. In North Carolina, I was the healthcare chair for the North Carolina NAACP for a number of years, and we've been pressing it at the level of the state. Since we weren't able to fully accomplish what we sought out to accomplish when we passed the Affordable Care Act, we've been trying to figure out what happens if we bring this work back to the state and do it at the state level. What happens if we're able to find models across the country that might prove effective to help people gain access to healthcare? And we've been working on this in North Carolina for a number of years. I've been working on the outside for a number of years, but in the last primary, I won the primary for North Carolina House District 106. I'm running unopposed, so hopefully that means I will be in the General Assembly come January 2027. But guess what? Now it's my responsibility to put forward a bill in North Carolina. And guess what? I don't know how to do that. So I agreed, and I want to turn to some other people who have greater experience working in general assemblies in Michigan, in New York, and in Pennsylvania to see if they have any insights that can help me as I prepare to take a bill to North Carolina. It might even help you all as you are working on getting a single-payer bill in your state as well. So today I'm going to introduce to you Senator Gustavo
Rivera.
Gustavo Rivera, please forgive me for mispronouncing your name. Representative Carrie Rheingans, I think I said it right.
Okay.
And also Representative Greg Scott.
You mispronounced my name.
Excuse me, Gregory.
There we go.
There we go. And we'll talk a little bit with them about where they are with bills in their state as well. So why don't we start off with Carrie today? If you don't mind introducing yourself a little bit, talking a little bit about how you got into the struggle, and then sharing a little bit about what your bill would do and how you would finance it.
Great, thank you. So I am State Rep. Carrie Rheingans from Michigan. I represent part of Ann Arbor and some rural areas around Ann Arbor. I'm in my second term. We have 2-year terms in the Michigan State House, and I introduced my bill called My Care in Michigan. I introduced it last term after being told not to introduce it in the first Democratic trifecta in Michigan in 40 years because my speaker thought that it would be socialized medicine. So that prompted me to realize that even Democrats don't know what healthcare for all changing into public financing would do, and it's not socialized medicine. So I introduced it anyway and did town halls across the state. In this term, I'm doing the same This bill has been introduced in Michigan before. Right now, I would say I got into the struggle. I worked for HIV and the AIDS organizations for about a decade before grad school, and then worked on health policy and realized there's a lot of issues in the world of health policy. The ACA did not fix all of them by far, and actually went made a couple things more accelerated. But then we have had a decade of sabotage of the ACA by the first Trump administration, and the one big bullshit bill, which is the final, I think, blow to the healthcare system, which is drastically collapsing right now as we speak. So just a very brief overview of my bill, and I'm happy to talk more about details later. I do have a handout for folks if you grab them on the way in. This is also online at carrierheingens.com/mycare. So it describes the bill, what it covers, how it's financed. It's basically all publicly financed using federal and state dollars to fund the MyCare Trust Fund. And this would be overseen by a board appointed by the governor with the advice and consent of our Senate. It would be comprehensive. In Michigan, we believe that your brain and your eyes and your ears and even your teeth are part of your body. So we think that those should all be covered.
Amen.
And so since our bill does use federal financing, we need federal approval. And that is a big old problem right now. So we're looking at the opportunity of the next 2 years to really work on this bill, gain momentum across our state, and then get a federal administration that will support and approve our bill at the federal level, or help pass the State-Based Universal Healthcare Act, which would help enable our bill as well. So that is a very brief overview of my past and my bill.
Thank you so much, Carrie. Representative Greg Scott, we'd love to hear a little bit about you, how you got involved in this movement, and
Yeah.
a little bit about your bill and House Fund.
Awesome. So I will say, almost ditto everything that Representative Rheingans said, with the exception of who I am, right? So Greg Scott from Pennsylvania. And it's interesting, my first foray into public service or government was when I was in 6th grade. My mom was a single mom, so when you're a single mom in my community, you take your kids with you everywhere you go. My mom went to the doctors, and I won't forget, the doctor said to her that the treatment you need for the health ailment that you have is not covered by your health insurance. But if Hillary Care passes the House tonight, you know, maybe it'll pass. So I went home and I watched NBC 10 News at 11 o'clock that night, and I saw that they spent 2 minutes and 30 seconds on Ken Starr and his investigation, and 30 seconds on Hillary Care failing to pass the Congress. And I picked up the phone. Back in my day, there was this thing called the phone book. I'll tell you about it. But I looked up NBC 10's telephone number, and I called the station and asked to speak to the reporter who gave the report. And lo and behold, they put her on the phone. And I basically said, hey, listen, my mom is sick. You spent 30 seconds on this very important thing that could help the majority of people that live in the greater Philadelphia area. And a longer span of time on that. Make an incredibly long story short, I wrote a letter to President Clinton about it, and he read my letter and said, hey, I want to meet this kid. In October of 1999, he flew Air Force One to Philadelphia for an event, and I had a chance to meet him on the tarmac and then have dinner with him at this restaurant called Zanzibar Blue, where I told him about my mom and how sick she was. She wasn't really that sick that she was going to die per se, but this was this thing that needed to get taken care of. I don't know how it happened, but somehow miraculously my mom got the care that she needed. It was the first time I saw government working for people. And so fast forward, now I'm in this position where I'm the state legislator. This is my 2nd term. And just trying to make sure that folks have the same level of access to care that I have, right? Like in Pennsylvania, as a state legislator, I'm afforded a platinum health care, where I can go in and get things done without referral fees, with very little copays. I went to the doctor the other day, and prescription, $3 for my prescription, for a name brand prescription. If it's good for me to eat, it should be good for everybody in my community to eat. My bill, like Representative Carrie's, also establishes the Office of Healthcare. There's a board. The board is appointed by members of the governor, the legislature, the attorney general. And much like hers, we believe that everything should be covered, right? I'm gonna steal your brain thing. I love that. So I'm glad this is being recorded. Because I gotta remember how you said it. But yeah, and so it covers all of that. Where we are at right now is that the last time this bill was introduced in a Medicare for All style was Representative Panda Lucio, who is no longer in the legislature. It was in 2017. Then it was picked back up by Representative Tara Khan, who's also a nurse practitioner and a doctor, PhD doctor, trained at the University, who still has a state representative, still sees patients every week in the city of Philadelphia. And then Representative Lindsay Powell of Pittsburgh. We've met with several stakeholder groups, some of the people I see in this room. We are probably going to be releasing a draft of introducing our draft in September when we come back after our budget session, with the exception to do more educating. We're taking a playbook straight from out of her. We're going to be touring. We start this summer. We're going up in State College next weekend. We're going to be going out throughout the Commonwealth of Pennsylvania. And more importantly, what we've been doing is having stakeholder conversations within our own deliberative body. In Pennsylvania, we have a 1-seat majority. Democrats have a 1-seat majority in the state house. And we're only as conservative, or we're only as liberal as our most conservative member. And 6 districts in our state house voted for 46-1 and the Democratic member. So we've got to make sure that they provide, that we can get stuff done. So we've got to protect our majority, expand our majority, with the hope that going into next session, we'll be able to get some public hearings. So I'm going to stop with this kind of like the brief overview of where we're at. Oh, I'm so sorry. Yes, much like hers, it's going to be 100% public finance. But there will be a payroll tax. So we will have a payroll tax. And we also have a handout that was provided by some of our stakeholder groups that that talks a little bit about this too. But yes, is that answer your question?
That really did. Thank you for a thorough job. Appreciate that, my brother.
Yes.
Senator Gustavo Rivera, and I want to apologize for not having Rivera before. I copied and pasted, and I had this R sitting up there. I'm like, what's this R? What does it need to be? And then I lost your last name.
No worries, you know it's only River.
River. I love it.
It's fine.
But you've got a bill that's been put forward pretty far advanced. We'd love to hear a little bit about how you got into this, a little bit about the bill, and how you find it.
Sure. Good. Good morning. First things first. Nixon 4. Anyway, so my name is Gustavo, U.S. State Senator for the 33rd District of Northwest Bronx. I'm also the chair of the Health Committee in the Senate, and I have been in the legislature for about 16 years. I've been the main sponsor of the New York Health Act, which is the bill in the state of New York to create a single-payer system since 2017. And there's a couple of things I agree with basically everything that's been said. I just want to add a couple of things. First of all, I want you to do a little exercise. I want you to close your eyes for a second. Close your eyes for a second, and you imagine that there's no Donald Trump. Look at that. You live in that moment where people are not getting snatched off of street corners, like American citizens not being murdered in the streets. You don't have federal agencies being used to hunt down political enemies. It's a wonderful world, isn't it? And in that world, people still go broke from getting sick, which is why this whole thing is an obscenity. Our healthcare system, before this knucklehead in the White House, was already designed not to keep people healthy, but to make money, and therefore to maximize profit does not equal keeping people healthy and alive. But we have a problem we have to solve. We believe that healthcare is a human right, and if you believe that, then you need to establish a system that actually makes it happen. It is not a unicorn. It exists in some version, in some way, shape, or form in every modern democracy in the world. So it's not like it's impossible, but it's incredibly difficult to talk about this. A few things that I want to mention though, and I know that we're going to get into this, but so as far as the bill is concerned, the New York Health Act will create a single payer system in the state of New York. Much like what my colleagues have been saying, no premiums, no co-pays, no networks, no deductibles. We do not consider teeth as a luxury loans. You can use that one if you like. It also covers long-term care, which is something that we added to the bill just a few years ago after some analysis. And it is funded by having a payroll tax, and a graduated assessment based on ability to pay that The first $25,000 of any person's wages are excluded, and if you are and then $50,000 if you are post retirement benefits. As far as Social Security, if you get that for Social Security, we're going to go back to that. But it would make it easier. Federal waivers, right? It is just as most folks know, obviously, Medicaid is a program that's roughly 50-50 done by state dollars and federal dollars. And over the years, states go to the federal government and say, hey, I want permission from you to use federal dollars to do special things. And then we get waivers to be able to do that. The state of New York has more waivers than any other state. So we've definitely been doing it for a while. We have a lot of different things in it. But, so if we get a waiver, it is easy enough to do. If we do not get a waiver, however, ultimately what we have to do is to be able to demonstrate to the federal government that we are not using any federal dollars for non-federally approved things. Which means, on the back end, something that does not impact providers and does not impact patients, but on the back end, it would cut down the savings a bit because we would have to build an administrative apparatus that would have to keep track of all that, but we do that now. In the state of New York, there are one of the few things that we pay for with state dollars that we do as a wraparound service. So these are some of the things that we've talked about, but we do not require a federal waiver, I believe. And we certainly, and my bill has 32 members we have 42 members in the state Senate, and 32 of them are sponsors of the bill. So a majority of the members are sponsors of the bill. There's other difficulties that popped up where we can talk about those, because I'm a little bit further along, which means that there's other things that y'all haven't faced yet that you will. So I'm dealing with those things, but that's kind of where the bill is going. Certainly looking forward to continue to have a conversation.
Thank you so much, and thank you so much for all of your very educational answers about how to go about it, how to get started, and where do we get this done. Just a brief question. How did you come up with a model to begin with? Where did you get your model from?
I reintroduced a bill that had been previously introduced, so I've been tweaking it since I've been a bill carrier. Right now, it is, we're debating whether we want to keep it fully, or if we want to keep it partially federal, partially state, for some of the reasons Senator Rivera mentioned. It would be nice to not have to deal with federal restrictions and things. However, it would be very nice to use the billions of federal dollars that come to our state from Medicare and from ACA tax credits, Children's Special Health Care Services, and Medicaid already. So that would cut down on the amount of money we have to put in through the state. So
it sounds like a difference between yours and the New York government.
Yeah, that's a major difference between ours, because we plan on
in ours too.
Yeah, federal and state sources.
Thank you. Greg?
I would just say that, well, one, since we're doing this in the frame of view that you are a new legislator in our conversations with you as the moderator, I will tell you that for me, what has been extremely helpful is that there are people way smarter than me on these issues that I've been able to lean on, number one. Number two, it's been already written and refined in a lot of other states. So our bill, if you look at our bill, it is damn near a copy of the Massachusetts bill, with refined to Pennsylvania language, if you will. I'll put it in Pennsylvania legalese, but ours is almost very, very similar to Massachusetts. And so the third thing I'll say is that we've got a leader in Carrie from Michigan who has organized state legislators across the country and put together a great toolkit we meet regularly. And so you're not alone in this effort. So we're there to help. She's leading the charge of that effort and making cross-state collaborations and also federal collaborations. And the last thing I'll say is that, you should meet her, she's amazing. But the last thing I'll say is that the interconnection between the states is incredibly important, because one of the threats, and I'm sure we're gonna get to more of this, there's a lot of threats, a lot of opposition from different angles on this. But one of the oppositions is, if you bring this to your state, business is gonna leave, and, you will be a less business-friendly state. Well, the more of us that do it, the better that is, number one. And number two, the federal government ain't coming to save us for any damn thing, let alone healthcare, right? And so I don't know what your district looks like in North Carolina, but I know what my district looks like, and I know what different districts across Pennsylvania looks like when I go and knock. Affordability is not a hoax, it's a reality. And the number one concern about it is healthcare, right? And so this goes back to the education piece. The more that you can learn, the more that you can educate your colleagues in the legislature and educate your constituents, because the other side has done a great job of painting this as the boogeyman. And so coming up with language that matters for you, we've gotten away from Pennsylvania, Medicare for all. We don't talk about it like that. We call ours the Pennsylvania Universal Healthcare Act. And we put everything on our branding on it. Like everything is Pennsylvania Universal Healthcare Act, because we want to create a new narrative about what that looks like. So those are just some tidbits.
And one thing I would add is that state legislating is the one, and as a part-time college professor, I speak with authority on this. It is the place where plagiarism should be encouraged. Steal my stuff, bro. If you get a pass in your state before me, God bless America. I'm good.
Yeah, it's a competition we want.
Amen, amen. So, and, I guess, Gustavo, where'd you get your model?
So my, I was just talking to a gentleman earlier about the guy who was the chair of the Assembly Health Committee. Before, his name is Dick Godfrey. He's now retired from the state assembly, but he served in the state assembly for 54 years before he retired. He's still a sharp bastard. He still gives me notes on my bills. He really does. But he introduced the bill in the late 90s. When he was approached by the Nurses Association, New York State Nurses Association, so a big union for nurses in the state of New York. So they approached him and they said, you need to be a champion for single payer. So they introduced a version of the bill, all that, like a long time ago. I picked up the bill when one of my colleagues left the Senate. So I picked it up in 2017, and since then there's been a lot of changes, further changes and tweaks. So it's been an evolving thing. And one thing I can tell you is that I do think that we have, I would not mind being beat by another state, right? If you get there first, God bless. But I do think that we are farther ahead because of the work that we've done, because of the research that's been done on the bill. We have, whether it's there's a study, I don't think anybody would call the Rand Corporation a liberal think tank, right? I don't think anybody would do that. But the Rand Corporation a few years ago did a deep dive into our bill, which told us that we would generate savings of upwards of $80 billion to our health system. And just this year, there is it's imminently going to come out. There's the good thing about economists who are like scholars. The good thing is that what they produce is a good scholarly, peer-reviewed, all sorts of stuff. The bad news is that you got to wait for all that really good to happen. So I've been waiting for this study that was done by economists that is current, that actually does a deep dive into the current bill and finds the same thing. We're talking about billions of dollars in savings and actually breaks down where that comes from. So again, we have a version that has been involved in for a long time, and we are, it's still in its, I'm always open, and this is something I tell everybody, we're always open, there's always an open door in my office to figure out if you're coming to me in good faith, arguing that there's something we should include in the bill, we include it.
Yes,
So somebody
I'm
include it.
just introduced already, but thank you. So you're leading me to that next question. How many times has it been introduced already? What was been the thing of it?
It passed the assembly, so every legislature will be different, right? The way that it works in the New York State, first of all, is that we have to have a bill that is we call it a same as bill, which means that both bills have to be word for word the exact thing. It's not the same in every state, not everywhere. Second, we have a bill like this has what's known as dual reference, so it goes to the health committee and is also reference to finance on the Senate side and to ways and means on the assembly side. So it has to pass out of my committee, the health committee, then it has to pass finance, then it has to go to the floor. So in the case of the assembly has passed it 3 times, and then The Senate, for those of you that don't know about electoral politics in the state, the very short version is that for a very, very, very long time, even though the electorate is Democratic, the Senate was controlled by Republicans. And there were all sorts of reasons why that happened. But the bottom line is that when we took over the majority, I told my colleague that got from the assembly, get ready because you're not going to pass the bill this year. And he was like, oh, of course, we passed it 3 years in a row. Of course we passed it. I'm like, no, you're not. And because the dynamics were now, wait, it can actually happen. It was easy enough to vote on the bill. It's just, it's just like, oh, I fight for this, knowing that it's never going to come out. So it got more difficult. We have not been able to pass it. I did get close a few years ago when I got my leader to appoint a working group, which she has done in the past for difficult issues, so us within the majority conference can fight it out amongst ourselves and come out with a version that we can move to the floor. But then redistricting screwed us, and that meant that a couple of the members decided not to run again because they were in the district now, and they had to compete with some people, blah, blah, blah. And for me, I had to move, so I had to go do a primary. That was a messy thing, so it just kind of broke my heart. So that's what's happened. And then this year was a bad session that we just ended 3 days ago. So, but I have plans though.
I bet you agree with your plans, want to learn from those plans. Greg, how about you? Tell me a little bit about the history of the time this bill's been introduced. Is this the first time, or is it moving through?
Yeah, so, I'm sorry, so we introduced, I just got this in my second term, so I'm 3 years in. In 2017, 2018, Representative Pam Delicio, who was from Philadelphia, introduced the bill. And it got introduced, and that was basically it. It skipped a session, then she came back and did it again in 21, and it was introduced again. And she had town halls in her district about it. But it didn't see the day of light in our committee, any of our committees. A CSM was introduced last session by Representative Tara Khan, and now this session, Representative Powell and I, we introduced the CSM in January. January 5th. Oh, thank you, sorry. We have all these acronyms. So a CSM in Pennsylvania, this is how the flow of the bill, right? So it starts off with a co-sponsorship memorandum. Hey colleagues, I'm introducing this bill on said topic. And then colleagues, along with stakeholders, external stakeholders also get that memo. And then they basically say, hey, I support it, I don't support it. Lobbyists will say, hey, I really like this bill. These are things I want you to include in it. Or they'll say, oh crap, let's go smother the crap out of this and make sure it doesn't see the light of day, right? So it's basically like a notice that, hey, this bill is working. So we sent out a notice on our bill this session on January 5th of this year, 26, so the second part of our session year. And from that, we've gotten a lot of stakeholder feedback. I also neglected to include in my bio, or in my intro, that I'm on the House Finance and the House Insurance Committee. So that was really intentional. I asked to be on those committees my first session. I've been on them this session because these committees will have a lot of jurisdiction, particular over this matter. So I don't know how your legislature is connected, but you want to make sure before you go in January that you look at your committee structure. If this is your priority number one, where would this bill be parked? Sometimes it may look like it may go directly to like a health committee, and sometimes it may not, right? Like find out what's better for you in your state, who's your committee chairman. Sometimes these people have like D names on them as chairman or whatever, but they're not really, they're like, anyway, so find out like how you, so we had to go as a CSM. We've drafted, we had 3 different drafts by our drafting lawyers. We have a drafting team that before a bill goes. And so we're in the middle of our 3rd draft right now, and we will introduce the actual bill language in September. And then our hope is to continue to educate, go around the state, and then in January, we will redo it again, introduce the bill, and push for a committee vote, an informational hearing, and then a committee vote.
So it sounds like this is a long-term process.
Oh my God, yes. Anybody that thinks that you just get in and shit happens is like, no, this is not, at least in Pennsylvania.
Yes. Thank you so much, Carrie. Sounds like you've
Yeah, so in the nineties, State Rep from Ann Arbor, Carrie introduced Mission Care, and that went over. And then, you may have heard, Congressman John Dingell Senior first introduced Medicare for All nationally, decades ago. And then his son, John Dingell Jr., was pushing Medicare for All for decades. And now his wife, my Congresswoman Debbie Dingell, is pushing Medicare for All. So like in the Ann Arbor area, we like do come by honestly to be pushing single payer healthcare. Our state rep before me, Yusuf Rafi, he introduced it a couple times. And all of these times before, never got a hearing. I've now introduced it twice, never gotten a hearing. Last term, in a Democratic press act, my bill was referred to insurance. The insurance committee chair was one of those Democrats that definitely did not have a hearing because Blue Cross told her not to. And this just brings me to remind everybody that the overwhelming influence of insurers in our politics can stymie these kinds of things. So I'm thankful that we have a ballot initiative in Michigan that would actually be a citizen-initiated law to ban large donors like that and our monopoly utilities from donating to lawmakers. And I've literally had people tell me this term when I asked them to co-sponsor my care, if they would, and 2 people told me no because it's an election year, and possibly mad, and they literally said that's why they're not doing it. So I personally am promoting that ballot initiative because once we get that passed, then I'll probably have more co-sponsors, maybe even get a freaking hearing in the state of Michigan, and be able to put this out for the people to really have a say. Right now, I'm just not in Michigan. Nope.
After all of these years of work. It seems, but thank you for keeping the flag.
You're welcome.
All right, we'd love to hear a little bit from you. Let's start off with who's been working with you to get this passed.
Well, can I say one thing? I'm sorry, I was trying to be respectful and listen. The interesting thing is in Pennsylvania, we have a maternal mortality crisis.
Yes.
And it's really disproportionately affecting Black women. And Black women are dying for what should be one of those joyous days of their life, right? Giving birth. And I have a 10-month-old who's right here. She's gorgeous. I had to leave her this morning. It was awful. But we have been working diligently to expand access to things like making sure all women, regardless of whether or not you can afford a blood pressure cuff or not, have access to a blood pressure cuff when they go home, because there's this thing like high blood pressure, right? We say, hey, we want everybody to have access to that. And the insurance says, oh my God, it's so expensive, it's so expensive. And then you look at the money they spend on campaign finance. And I'll be the first to admit, yes, they've also written me checks in my campaign finance, for campaign PAC as well. But it's like, wait, we can't have our cake and eat it too, right? And then you look at some of the money that is flowing, right, through these corporations. And as I've been a student and trying to study this more, it is like you can't have what we want and not have campaign finance rules. Pennsylvania has some of the most lax campaign finance rules in the country. And the amount of money that is spent on this stuff. So I don't know what they're looking like in North Carolina, but I did not know that going here. I was like, oh, I joined the insurance committee. Next thing you know, I'm getting checks and finding all the committees. I get all these checks. And I'm like, oh, this is great. Let's call time, right? And I'm like, oh, this is what they're paying for, right? So I did not understand.
This is what they're paying for.
Yeah.
They're paying for your vote.
No.
Well, no.
Trying to purchase it.
That's
Trying to
technically
purchase it.
illegal.
Yeah, no, that is a very good point. So no, there's no clearly they didn't, they weren't effective if they didn't. But what I will say is that it costs a lot of money to run campaigns today. And by virtue of who you talk to, the more that you talk to an individual, regardless of whether or not you agree with them or not, you have more access to them, right? So if someone is coming to your fundraiser, they're gonna see you. It's a captive audience. Nobody's getting through the door unless they pay, right? So you're having that conversation with them. And so you learn more about their perspective, I guess is what you're saying. But some people, and I don't know how you guys do it, but for my, the way we run it is, I don't really pay attention to it per se, just because I suck at fundraising, and I'm fortunate to have the ability to be able to self-fund a lot of my stuff, right? But not everybody has it. There's an equity issue with respect to campaign finance, which is why I'm for public financing, right? So that we can have more people in the game with various backgrounds. But I just want to point out the fact that like the campaign finance piece is huge. Two, everyone wants to talk about fucking money, but like the reality is the Rand Corporation.
But what was that word you used to see the money?
The Rand Corporation?
No.
Yeah. Oh, I'm so sorry, Pastor. I'm so sorry.
It was supposed to be the New Yorker version.
Come on, I'm so sorry. My grandmother is looking down from heaven. I apologize.
Thank you. That was wonderful. Thank you for that answer.
So I guess,
Carrie,
you know,
back to-
who's for and against, I would say, obviously, insurers are against, because it would make them obsolete, and we know that in Michigan, that's why in my bill, we actually wrote in a hiring preference for anybody losing their job because of the closure of their health insurance company. We want to hire them in my care, because we're gonna need thousands of people who know how to do these processes and, pay for services.
bingo.
Yeah. So do you have that bill?
We do.
Yeah. They go.
And we have a couple of
Something
them,
to think about
probably.
there, Dr. Sadler. So insurance companies, health insurance companies are very much against this. We've been working with the Michigan Nurses Association, which is one of our biggest supporters. They're the Michigan chapter of National Nurses United. They're a huge supporter. And the state level AFSCME is actually one of our biggest supporters. Now, I know that is a difference in New York, which is something that is very interesting as we're talking amongst ourselves as states. So those are some of the biggest supporters as far as labor. A lot of the professional associations are varied, right? So over time, the American Medical Association has not been super supportive of universal healthcare finance. And so those dinosaurs are dying out, and the young students are coming up. Medical students are much more in support of universal healthcare. So we're working with our local chapters, and then there is a state association in Michigan for single payer healthcare. And a lot of states have these, but not every state has like a single payer Medicare for all type group. And if your state doesn't, you want to get started. Because state lawmakers in your state need help, and you will be able to help it. And then of course, one payer states, there's a brochure outside, is a national organization that is really trying to help win Medicare for all through the states, doing it state by state like this. So that's a group that could use some help in each of the states too. So later we'll talk about which states don't yet have a bill, so we need your help finding lawmakers in those states so that they can introduce bills and be part of our crew of learning from each other.
I love that idea. And thank you. And then Greg, as you answer this question, could you give us any unusual suspects that you found support?
Well, I will say the number one support that we have for this is the people power, right? Like I would say that the people power behind this is incredibly important. Even the folks that don't know what it is, the more you talk to them about it and the more you talk to the way it works was. Our state chamber is actively opposed to it. We have this thing called the Commonwealth Foundation in Pennsylvania that's based in Pennsylvania. They are funded by like one of the richest men in Pennsylvania. But anyway, they are actively opposed. One of the things that I think is very interesting that the chamber is opposed, but we have rank and file small businesses that when you explain to them what it looks like and how it would actually work, they actually like it. And then when you say, hey, there's also an option for you to cover your employees' portion of the tax, they like that, and they find that it could possibly be cheaper than what they're paying right now. And so they like it. And so one of the things, and I know that this is a live stream, so I want to be careful of like not giving too much of my strategy. But I think one of the things that's incredibly important is going back to you is like the education piece. Instead of going with like your state lobbying, for especially some of the conservative ones, like focus on some of these regional ones, focus on some of the smaller ones. And one of the successes that we have had, for example, is universal childcare, which is a big thing for me. Our local chambers are for that, right? But our state is not, right? So like local employers understand that if my kid can go to daycare, that means my employee can come to work, right? Like this is an economic development issue. So we've gotten a lot of that. Again, the same players that are working in both the Nurses Association, those folks are all. But I would say the biggest one to lean into is just your people power. Our state Democratic committee also has a caucus that is dedicated to this. I don't know how your state Democratic caucus is structured, but we are I believe they passed a resolution or are in the process of passing a resolution with respect to our state Democratic Party, which then sends out a notice that, like, hey, we want this to be included in the national platform, our state platform. So that gives a level of credibility as well.
Thank you so much. I appreciate that. Gustavo?
Yes, so for us, certainly the Nurses Association, as I said earlier, they brought the bill originally to my colleague in the Assembly, my former colleague in the Assembly. And since then, we certainly have we have some union support. We have some unions that are not supporting, but I'll get back to those in a second. We also have a lot of local organizations around the state and a lot of advocacy organizations that have been talking about the bill. Ultimately, it needs to become a political liability not to be supported, right? And that's the way that I've always functioned is in politics or politics and government. You do one of two things: you either show people the light or turn off the heat. So you educate them, and if they don't come around, it's like, all right, cool, we're going to put pressure on them. And so it has to become a political liability not to be supportive of it. It has not yet done that in New York. It has not crossed over. And the reason it hasn't crossed over, get to those in a second, because I want to talk about the opposition, certainly insurance companies. In the state of New York, there are no for-profit hospitals, but there are plenty of, like, all our hospitals by law are not-profit. However, there's many of them that act like they're for-profit. And so so certainly they're not fans of it. But the biggest and most tragic reality in the state of New York is public sector unions. Public sector unions, the largest, so the way, for those of you that might not know, so AFSCME, which is the Association for Federal, State, County, and Municipal Employees. If you ever wondered what that big ass acronym was, that's what it is. And there are, because it represents public workers at all levels, it means that there might be a couple of places where you have, like, there's 200 employees here, there's 5,000 employees here, there's 20,000 employees here, there's 75 over here. So there's all sorts of these different locals all across the state and all across the country. And in each one of these states, there are district council, or DCs. So district councils represent a whole bunch of unions. And in the case of AFSCME, the largest district council in the country is known as DC 37, which represents the state, the municipal employees who work for the city of New York. And so they have been the biggest opposers. And the unfortunate reality is that they have done so because of resistance from the leadership, which at times has, and I know it's being livecast, and you might see it in the future, brother, but we have been lying about the bill, bro. You're lying about it, bro. You're lying. And it's sad, but there's obviously other things. There's good faith arguments that can be made. The good faith argument, and some folks have absolutely made this argument. Public sector unions in the state of New York have the best healthcare coverage that is currently available. It's still an insurance product, which is where this all falls apart. But they have an insurance product that, in comparison to most other insurance products, is wonderful. And they got it in their hand. So I call it the bird in the hand problem. It's like, I got it here. You were telling us that we have to give this up. But what do you got over there? I got this now. And we fought for this, and we gave up so much for this. So they're like, can you give us back what we gave up to get this? The answer is no, I can't give you that back. But I can give you the ability to never having to fight for it again. Yeah. Right? And so there's two more pieces to this that I want to mention. There was a crack in the wall, as I call it, because long story short, there was a change that something called the Municipal Labor Council, which makes up the public sector unions in the city of New York. It's a large employer. They started looking at the numbers, and they figured out that unless they changed something related to how they delivered how they paid for their care of their members, that the fund was not going to be fiscally sound. It was falling apart. And so they made the decision to change the way that they provided care to the retirees by shifting the retirees to a Medicare Advantage plan. And the retirees were like, I'm sorry, what? And obviously retirees have a little bit of time on their hands because they're retirees, and they did an amazing job of organizing against it and have so far been able to put a stop to it. But the good piece is that now they're asking questions. They're asking questions of me, and they're saying, if the New York Health Act was in effect, would we have had to do this? And I'm like, funny you mentioned it. No, let's talk about what the bill actually does. And let's just did a Zoom, I put it on the screen, it's like, oh, put this on screen. So you can kind of see, oh, that thing that you said that, no, it doesn't do that. Tony, put it on the screen. And they put it up, we read it together, and we said, this is actually what you told that it does this other thing, no, it does this. And so there's a crack in the wall, and so there's people organizing within the unions, as well as UFT, which is the United Federation of Teachers, which is the largest teachers local in the state of New York and one of the largest in the country. They have been somewhat opposed as well, but not as strongly as DC 37, and there's cracks there too. Last thing I'll mention really quick, because this is the important. There's somebody that as far as studies itself, there's an economist who on her free time, God bless her, came up with it, just asked herself a question. He said, wait a minute, we're talking about public employees, we're talking about public sector. Counties in the state of New York, there's 63 of them. Do counties have employees? Yes, they do. Do county employees have healthcare insurance, but healthcare? Yes, that's paid for by their employer, yes. How about, what would happen if we just asked each one, just went to the public information that's available for each one of these counties? How much do they spend a year on health insurance? Just that number. Let's ignore the number of the amount of money that they might need to do to manage the benefits for their members, which is something that many counties have to do. Let's just ignore that part. Let's just go with one number. How much they spend on health insurance? And let's say that we now funded it completely differently. Let's say that we funded it with a payroll tax. Anybody that makes $25,000 or less, that gets ignored. Anybody that makes $25,000 or less, payroll tax, 100% of the payroll tax covered by the county. They started, did some math, found out, in the case of Suffolk County, for example, it would amount to a 92% reduction. What? I'll bring it back. So this county of Suffolk, it's one of the counties in the state of New York on Long Island, has a $4 billion budget. Yes, all right? It's a large bill. Of that, 582 million of it goes to employee health insurance. It's 14% of the total budget. 253 million of it is for the mandatory Medicaid county share. That's something else that we can take. And that's 13.6 is health plan cost increase in just 1 year, right? So 582 plus 253. So we found out, and we just did the numbers. We just said how many employees you got, it's like we just calculated, and it says that it would mean that you would go from paying, with included county share, 812, the exact number is $812,469,752 American dollars, to $67,457,201.
That's amazing.
That would be a savings of 92. And then we did it for every county and every single one of them. And we just got this little thing, and I gave it to my colleagues, the ones that are kind of on the fence. I'm like, you got counties? See, because in the city of New York, it's so compact that we have 5 counties, but I represent just a chunk of one county, and I got 325,000 people in the district. But when you're upstate New York, when you're upstate New York, you might have 1, 2, 3, 4, 5 counties, and I'm like, so that is something that you could potentially do in your neck of the woods. And we could actually provide you with, I'll get you this. And also I'll get you the Excel spreadsheet so that you only have to probably do a couple of tweaks, but it's simple enough. You just drop the number in there and boom, it will actually provide.
And I know, Dr. Sadler, we're trying to move to allow some questions from the audience.
Yes.
But one thing I want to say, in Michigan, some really, entrepreneurial grad students at the University of Michigan worked together on an independent project to try to use AI to come up with like a study of how much money we would save in Michigan on this. And I am looking forward to reading their report, but they are saying it's very promising. And of course, there could be flaws with this analysis, but we're working with Michigan Personal Payer to also develop a study done by human intelligence with health economists at the University of Michigan as well. So there will be a lot of these kinds of studies and numbers that may be replicable. And one of our colleagues in Colorado, they are working on the final public pieces to finance a study there, that would study through the University of Colorado School of Public Health. They would create some sort of, form or, spreadsheet that can kind of, you can plug and play your own state's numbers in, and it will tell you about how much it will cost to save in your state. So we've talked to our colleague from Colorado about that as well.
Well, I look forward to this, and you all have answered another question that I had is, how is it helping to work with other states in this? It seems like there's a lot of camaraderie.
Oh, I think it's vital. I think it's vital. It's certainly vital. The only other thing I will add, because I know we want to get to questions, it's really important, but the other thing that I would add is that, and this is why it's so important to have each state do their own, figure out what works for them, the best thing that works for them. But we wear a lot of red and blue jerseys. A universal language that works in all 50 states, including Washington, D.C., is the green jersey, the fiscal impact, right? That's always going to be the number one argument from the other side. So getting an understanding of the fiscal impact is incredibly important. The second point that I would say is that there's some models where you can have the public option, but still have private. So like, if you look at France, 92% of people in France have the dual insurance, right? Like there's now in ours, like in Canada, for example, a lot of dental and vision is separate. It's a private thing, where ours in Pennsylvania would not be included. But there is a world where you could have, two. In fact, I think in Medicare for All and Senator Sanders' first generation, and even the current one, there's correct.
Very good. Thank you so much. I want to invite those of you out there who have questions to come up and form a line behind the microphone here. Is there a microphone?
Yeah, there's Mike, you can use this one. We're recording and we have folks online, so if you do have a question,
Come on up,
please
come on
stand
up. Right.
And one thing I will say as people are lining up is that we do have a number of states that we need bill sponsors in. We have a plan of introducing a bill in every one of the 50 states in the first quarter of 2027 so that we can build the momentum to force this conversation in the 27-28 presidential campaign. So if you know your state lawmakers, I'll have a list out there afterward of who we still need bill sponsors for. So come tell me who to bother. Because I just pulled all these guys. And I will just do it to the other people that we need that too. Yes.
And thank you for organizing. Dr. Sue.
I'm over to on the topic. All of you are going to be faced with these Medicaid cuts. And October 1st, as you know, all immigrants are going to lose their health Medicaid. So in some respects, it's going to force the hands of every state to try to figure out what are we going to do to address this. The silence around this and the lack of conversation, at least in the major media, about this is pretty striking to me. So I wonder if you see this as an opportunity for all of you.
No crisis, no waste, I actually think, as I stated earlier, that little experiment with closing our eyes will have again. Things were bad before. Things are just going to get progressively worse. And when I'm looking across, like I just had a debate the last days of session with my other colleagues. I'm looking across and I'm saying, how many of you have come to me in the last 5-6 years telling me about a safety net institution in your neck of the woods that's about to fall off a cliff, and you came to me for help? So don't tell me that you don't think that these things we need to do, because you're in the most rural states, or the reddest part of the state. You still have need of what we're talking about. So I think that this crisis needs to be taken advantage of to point out how broken the system is and how to potentially fix it.
So one thing I say in my state, in Michigan, is that the healthcare system is collapsing. It looks like these problems that we're experiencing, but it is causing, the reason we're doing town halls across the state is to fill people's mouths with what they're gonna demand once the system is fully collapsed. And so the public sentiment, the people power that Rep. Scott was talking about, that we have, people want this. 65% of the American public wants this. And when you tell them it might raise their taxes, guess how much they'll want it? 63%. That's a majority, okay? So the people already want these bills, and every chink that happens in our system and all these chains that are breaking to catch people, this is only gonna make it more that the people want this. And so I think, like Gustavo said, Senator Rivera, the crisis is not going to be wasted by us just scrambling around. We're going to be able to build a new way forward, and that's using this healthcare for all publicly financed model.
Thank you so much, please.
Thank you. And I'm in Texas, it's very red, also the highest uninsured.
For now.
Yeah, it's red for now.
Right now, and, but it does have like the highest rate of uninsured people in the country. So, I imagine it'd be difficult to try to do this at the state level. Have there been iterations where county or cities can take on doing, this type? It's just not feasible because of the network issues and the.
Well, the amount of risk pool, right? So like a county might have like a lot of people in it, and there's some counties in our country that have more people than a whole state, right? Wyoming, looking at you. But like the risk pool to make the math work is hard. So it would be hard to do at the county level. There may be some counties in Texas that can try it, and there's folks watching online who might be willing to connect to talk about that, but.
So the one thing I will say is this, is that in Pennsylvania, our counties have a lot of responsibility. They have a responsibility for housing and homelessness. They have a responsibility for providing, 911 services, so they have that kind of data. In Montgomery County, where I'm from in Pennsylvania, we've received so many mental health situations and lack of care, access to care, that we are opening the first 24/7 mental health hospital that, as long as you're a resident of Montgomery County, that you can go in, similar to going to an ER, right? You can go in and you have a mental health crisis. There's one in Dauphin County in Pennsylvania, but it's not 24/7. And so what inevitably is gonna happen is that they're gonna start seeing gaps, and we're seeing in Montgomery County, people are gonna be dying more, and we have healthcare deserts right now in all parts of our Commonwealth. I think these counties are gonna start speaking out and saying, hey, we can't absorb it. Not everybody is wealthy as Montgomery County that can absorb this level of care. So they're gonna keep lobbying, they're gonna be key lobbying partners, but I have not personally seen it.
The first state to actually pass on both houses and actually have some sort of implementation or an attempt at implementation of single payer was Vermont. And the thing is that before it went into effect, the government pulled the plug. And just as it was about to go to effect, part of it was because they figured the financing just didn't work. Partly because of the size of Vermont, because of the tax base, etc. It is the reason why I consistently tell my colleagues, we don't have an opportunity in the state here, we have an obligation in the state here to demonstrate that it can be done. And by doing that, by the way, this is something that, for example, in Canada, it did not happen across the country at one time. Saskatchewan, which is one of the provinces, did it first, and ultimately it went to other provinces. So one of the, to kind of answer the question that was stated earlier as well, as far as whether collaborating with other states is helpful, phenomenally helpful. Because the thing is that as we figure out how we get in our states, once we get past the coast and we manage to get it over the finish line in one state or two states, the likelihood of us figuring out how to then collectively be able to maybe merge, just be able to do it across state lines. Because there's other things that we can do that are we don't require federal approval for, that might actually allow us to be able to build that up to demonstrate that we've done also. At the county level.
All right. Thank you so much. We've got a couple more questions in a few minutes, so jump on it.
Hi, I'm Dr. Scott Tyson for Pittsburgh. I want to reiterate what you said, the professor said. Steel bills, make them and tweak them.
Amen.
Yeah, seriously, they have done the work. A lot of people have done the work. Steel. The other thing I want to mention is Representative Latasha Hayes out of Pittsburgh, who has spent 2 years working on the African American infant epidemic. We have worse outcomes in that community than Cuba does. This is a shame and criminal.
1000% as our next speaker is coming up. You're right. We have a great Black maternal health office led by Latasha Mays, Morgan Cephas. They're making a lot of inroads in this. Google PA Omnibus.
I'm on the west side. We still need it in Michigan.
Hi, thanks. I'm from New York. Very simplistic question. And so apologies for such a simple question. Does this eliminate employer-sponsored health insurance across the board?
Would no longer be necessary.
So particularly in New York, you've got large financial firms, large national nonprofits, who I imagine will be in favor of this because it would save a ton of money. Where are they in the conversation?
We're bringing them along. Like we're actually working with, just like employers, because one thing we haven't mentioned, I think it's important to mention it. It's not just, there are certainly established interests that do not want this to happen. But the other thing that we cannot ignore is the fact that it's baked into our heads that the way to get good healthcare is to get a good insurance product. It's kind of, we all assume. We seek a job that has a better insurance, we stay in relationships because we have insurance, we have, like, all these things. So we just assume that that's the way to get it. So the notion that we can actually do away with insurance companies and have it be a better system is something that for a lot of people just doesn't, it takes a while to calculate. So,
I wanted to skip that last question.
yeah.
We'll be out in the hall afterwards.
Yeah, so I was just wondering, without giving too much away of your strategy, what have you seen in the past that's most effective from the public to sort of turn up that, pressure liability that you're talking about?
Yes.
I would say go to the people. Like I mentioned earlier, in Michigan, I haven't been allowed to have hearings, so I don't need to have hearings in Lansing. I can have hearings with the people. So I'm taking this to the people on a statewide tour, and I heard you say you're starting that. You've been doing that in New York. And so the more people who know about this and can demand it, there are way more people who want this than special interests who don't.
Yeah, I would say part of it is, in any random room, go into any random room and just ask a few questions about experiences that people have had with insurance companies. Any room filled with more than a couple of adults, they will be able to tell you something about themselves, their family members, their kids, what have you, or their neighbor, that was just choices being made that had nothing to do with their healthcare, having to do with whether they can afford it or not. So you take on that and then you say there is an option. We have options. We don't have to continue doing this. So it's about making that connection and saying, depending on the state, there's a legislative option here that we can pursue. And so therefore we have to demand of our state legislators that they make it a reality. And at the state level, it is so much more possible than the mess that's happening in DC right now. And this is why the states are also so important, because we get that at the state level. We can get stuff done at this level that can't get done at the federal level.
Yeah, and people talk about accountability, like the reality of it is this: every time I talk about healthcare, in fact, sometimes I don't even have to bring it up. Their relative has cancer and the insurance is denying this, or the insurance is denying this level of treatment, or you need a 10-page referral for this, or you need an authorization for that, right? So you have a system that allegedly is there, people think it's working for them, they think they have platinum coverage, but the red tape is crazy, right? And so lifting that up is incredibly important. We have an opportunity to help change that system.
Very good. Let me just say, what a wonderful panel, what wonderful information to share. Let's thank Representative Carrie Rheingans.
Can we just do one thing? Because Carrie's she's like this whole QR code. I'm not sophisticated, but if you have read my bill and you want to provide comments, you can reach me at revscott@pahouse.net. I don't have a QR code. I'm not fancy like representative, but I will get that. Revscott, REPSCOTT @pahouse.net or 484-685-3494.
Very good. Thank you, Greg, and thank you, Gustavo, Rivera, A and B. Thank you so much.
Representative-elect Sadler.
Thank you so much for coming out, and please make sure you take this home with you. Make sure that you get something working in your state. God bless you all.
Tip your service.
All right, so I know we're done in the live stream, but if you guys